And now welcoming to the stage Professor Ahmed Fahal, come on. And I'm not giving lengthy biographic details here because you have that in your materials, but it's worth sharing that Professor Fahal is the director of the Mycetoma Research Center, working on, it's not something I knew very much about, but it's a terrible, neglected tropical disease that he's doing amazing work on in Khartoum in Sudan. I really encourage you to check out this organization and the work that they're doing. And he's here to share with us the study looking at once-weekly phosrovuconazole versus daily itraconazole with surgery in Mycetoma patients in Sudan, a randomized double-blind phase 2 proof of concept superiority trial. So Professor Fahal, the floor is yours.
Madam Chair, ladies and gentlemen, first I would like to express my sincere thanks and gratitude for the opportunity to be invited to be part of this highly reputable meeting. My name is Professor Fahal. I'm a professor of surgery, director of the Mycetoma Research Center, Sudan. I'm going to talk to you about the first ever double-blind clinical trial for a new drug for mycetoma patients. I would like to confirm there is no conflict of interest in this presentation. All photos were taken after informed consent. Ladies and gentlemen, mycetoma, it is one of the badly neglected tropical diseases. In fact, it is the most neglected of the neglected tropical diseases. It is a chronic granulomatous inflammatory disease caused either by bacteria or by fungal of foreign origin. It is characterized by massive deformities, disabilities, destruction, and stigma. It affects the poorest of the poor in poor remote regions. Most of the important information about mycetoma, it is still unclear and not well understood. But the fact that this neglected tropical disease is neglected by the international communities, a lot of this information are not available. I want to say that it is an endemic in tropical and subtropical regions, but reported worldwide. Currently, the treatment outcome is suboptimal. Likewise, the diagnostic tools for mycetoma are not very much in line with the international standards for diagnostic tools. In this study, we compared two drugs, phosrovuconazole and itraconazole. Apology for this busy slide, but I would like to summarize that itraconazole, it is not easy to use, high risk of drug-drug interaction, problem with absorption, especially with certain type of food. On the other hand, phosrovuconazole, it is a mature antifungal drug, has a high solubility, a very potent drug with a minimum side effect, and that drug was produced and developed by Eisai company in Japan. In this study, which is the first ever double-blind phase 2 proof of concept superiority trial of phosrovuconazole 200 milligram versus 300 milligram given once per week. This is two drugs. This drug with two arms were compared with itraconazole, the standard of treatment 400 milligram daily. The patient usually takes 4 tablets per day with itraconazole and 1 tablet per week for the phosrovuconazole. In this study, we randomized patients in 3 arms, 200, 300 milligram phosrovuconazole versus itraconazole 400 milligram per day. The plan was to continue for 3 months, and then we do an interim analysis and to drop the loser arm. And at 6 months, we conduct surgical intervention, and then we continue for another 6 months to trying to reduce the rate of recurrence. The study started in 2017. The plan was to have 138 patients and to include only 20 patients because that time we were not sure about the safety of the drug among ladies. Single lesion in single anatomical site, and all the patients should have medulla mycetomatous confirmed by PCR, and you have MRI ultrasound confirmation. However, the DSMB, after interim analysis, the first one, after 84 patients completed 3 months treatment, found that there is no superiority in which arm of the vozorovoconazole. And there is no need to drop the loser arm. So we continue with the 2 arms, but we increase the number of patients to 165 patients. And then to lift the restriction on the female recruitment in this study, because it was found to be safe among these ladies. Then a second interim analysis, after 104 patients completed the 3 months treatment, said that we have to stop the drug because the overall blinding cure rate was approximately 65%, more than the expected rate. And due to the slow recruitment, COVID came in the scene, some local issues in the Sudan, and there is no superiority of the vozorovoconazole over the itraconazole. And there is no safety issues about this. And this is our population. It showed that we have 34 patients in the 3 arms, in the 300, 34 in the 200 milligrams, and 36 in the 400 milligram. And you can see the intention to treat, and then you have the modified intention to treat, and the per protocol population. The exclusion were due to some of the patients did not attend some of the visits, the surgical intervention, and missing one of the surgical intervention, and then some of them have a poor compliance. The clinical presentation, the history of the patients, showed no major differences between the different arms regarding the age, the sex, the clinical presentation, and this. And interesting, even a small lesion have the same duration of treatment. And we are not sure of how is this. Regarding the size of the lesion at 6 months time treatment, again showed no significant differences between the 3 arms. And that may be with these antifungal drugs lead to more capsulation, fibrosis around the lesion, making it static, or it may be increasing in size with this fibrosis. Regarding the primary effective outcome at 12 months, end of treatment, a modified intention to treat population showed that itraconazole had almost 75% cure rate, compared with 64 for the 200 milligram, and surprising, only 50% cure rate with the 300 milligram. Probably the higher dose was not very effective than the 200 milligram. Again, for the per protocol population, the vozorovoconazole had the highest cure rate, 84.6%, followed by the itraconazole, 80%, and less cure rate with the 300 milligram, vozorovaconazole at this site. Efficacy conclusion showed that there is no significant statistical differences between the three arms of the study. There is no superiority of the vozorovaconazole over the itraconazole, and the treatment in the three arms was almost the same. The secondary effective endpoint again showed that there is no correlation between the age, duration, symptoms, and the baseline size of the lesion and the size at 6 months duration. And again, there was no significant differences between them. And this is showing that the treatment emerged adverse event at the end of the treatment showed no significant changes or concern. It's safe drug, safe for the three arms at this side, and most of these were mild side effects. Safety. The treatment given in the three arm was well tolerated. There is no serious, severe adverse events or emerge treatment-related events. And the limitation of the study showed that we are dealing only with small model lesions only from one anatomical site, and the patient was from Sudan, and that was a limitation. The way forward that we need to do more work on other populations, patients with massive lesion, with bone involvement, lymphatic spread, and we have to look into the drug safety in young groups, children, pregnancy, longer duration, when to do the time, what is the time of surgery, and when to do it. I would like to acknowledge our Mycetoma assistant staff for conducting this difficult, complicated study, and the DNDi initiative for supporting, advice, and funding the study. Erasmus Medical Center in Rotterdam for conducting the microbiological studies, and Eisai Company for developing and providing the drug used in this study. And I would like to acknowledge and thank all the donors that made this study feasible, and the result may be applicable in the future in Sudan and other areas where mycetoma is endemic. And thank you very much for your kind attention.
Thank you very much, Professor Fahal. I'm not seeing, oh yes, there is one question that has come through. Are there plans to evaluate whether a combination of drugs could improve cure rates as opposed to a single drug administration?
Combination of drugs. Again, that depends on the type of drug to be used. Is it static, or is it eradicating the organisms? Is it synergistic or not? But so far, we are not sure whether that will be effective or not. But again, that will be a good opening for a new trial where you can have a combination of drugs. Currently, the available drugs, I don't think they are eradicating the infection. They're creating a good amount of fibrosis around the organism, and that can facilitate the surgical excision of these masses. So looking for a drug that can affect the organism itself, and as you know, Madrella mycetomatous, it is encapsulated in a very hard grains substance, and we need to do something with these substances and to attack the organism themselves. But the available antifungal drugs actually are only encapsulating, leading to fibrosis around the lesion that may enhance and may help in the surgical excision of these masses.